Video assisted thoracoscopic surgery VATS. VATS refers to visualization and performance of intrathoracic surgical procedures using a thoracoscope with a camera transmitting to a video monitor, freeing both hands of the surgeon to manipulate instruments through separate ports. VATS versus open thoracotomy. Incision. For VATS, it avoids large incisions and reduces postoperative pain and improves the recovery. In open, it requires large incisions and traumatic rib spreading. Visualization. VATS has high definition video magnification for highly precise dissection. In open, solely on direct unmagnified vision, the surgeon has to rely. The procedural requirements. VATS requires high expertise and skilled personnel and has a steep learning curve. Open thoracotomy, standard surgical training is sufficient. Risks. Because of the steep learning curve, VATS is associated with major hilar structure injury. In open thoracotomy, higher systemic trauma and pulmonary complication rates are noted. Indications. The diagnostic indications. VATS provides excellent visual access to investigate unclear endothoracic presentations, including number 1, pleural pathologies and malignancy. For direct visualization and tissue sampling of suspected primary or metastatic pleural diseases, it can be used. Parenchymal and structural lesions. Evaluating lung cysts, lung abscess, and emphysematous bulla can be done. Infectious diseases. Investigating complex presentations like tuberculosis. Therapeutic indications. It is utilized as a minimally invasive definitive treatment approach for resections, excision of lung cysts, and formal lung resections, example lobectomy and segmentectomy. Functional and mobilization procedures, cervical sympathectomy and esophageal mobilization for esophageal carcinoma is done. VATS can also be performed in patients who are unfit for open thoracotomy, for example, pulmonary compromise, cardiac dysfunction, extrathoracic malignancies, brain mets from solitary lung cancer, deep pulmonary metastasis requiring lobectomy. Poor physical performance. Performance status equivalent to Zuboff score of 2 or 3. Morbid obesity. Rheumatology and orthopedic conditions. Spinal diseases, rheumatoid arthritis, severe kyphosis, SLE, osteomyelitis. VATS can be done. Even in patients aged above 70 years, it can be conveniently performed. Patients with vascular problems like aneurysm, severe peripheral vascular diseases, it can be utilized. Recent or impending major operations. Even though the patient has gone an urgent abdominal operation, joint replacement requiring use of clutches, it is and there is a need for contralateral thoracotomy, it can be conveniently done. Psychological and neurological conditions, substance abuse, poor command following, and pain syndrome. Immunosuppression or impaired wound healing. In recent transplantations and diabetes, it can be noted. VAT setup, anesthesia and ventilation. A double lumen endotracheal bronchial tube is utilized to achieve single lung ventilation, collapsing the target lung to provide adequate visualization and operating space within the hemithorax. Patient positioning. The patient is secured in the lateral decubitus position with the disease size uppermost. Port strategy. The exact number of port varies based on the surgical complexity for standard drainage and biopsies. A single port can also be commonly employed. The incision scale. Access ports range strictly from zero point 0.5 to 1.2 centimeters in length. Primary access, typically established in the fourth or fifth intercostal space, anterior axillary line for hilar dissection. Geometric spacing. Two additional trocars, 5 mm or 12 mm, are placed a handbreadth away to ensure optimal triangulation for camera and rigid instruments. Insufflation pressure. 8 mm pressure is maintained. Critical structures reflected or divided are the phrenic nerve, which is reflected, Ligament of Marshall which is divided. Sinuses utilized are the transverse sinuses superiorly, oblique sinuses inferiorly. Energy modality used are the bipolar, radiofrequency clamp and linear ablator. Hybrid collaboration, close coordination with an electrophysiologist for follow-up of endocardial completion. Types or the approaches that can be utilized in VAS are the unilateral approach and the bilateral approach as per the procedure demand. Procedure steps in pleural effusion, drainage, biopsy and talc fluorodesis is done. Indications: it primarily is indicated for undiagnosed or malignant pleural effusion. Objective: complete evacuation of pleural fluid under direct visualization. Acquisition of multiple targeted pleural biopsies from suspicious areas. Uniform insufflation of talc across the visceral and parietal pleural spaces. 2. Induce fluorodesis and prevent fluid reaccumulation. Debridement of empyema. Indications: pleural infections that have evolved beyond simple free flowing fluid into fibrinopurulent and loculated stages. Surgical action: the pleural cavity is accessed under single lung ventilation. Loculations are broken down and thick inflammatory fluid and infected debris are vigorously debrided. The visceral pleura is freed sufficiently to allow complete re expansion of the underlying lung. Dependent drainage. Chest drains are strategically placed at the end of the procedure to ensure optimal continuous dependent clearance of residual fluid. Decortication. It is required when an empyema has progressed to form restrictive fibrous cortex or peel that entraps the lung, preventing it from re-expanding even after standard fluid drainage. Surgical action. It involves meticulous dissection to strip away restrictive parietal and visceral fibrous cortex. High priority is placed on avoiding injury to an underlying visceral pleura to prevent persistent air leaks. Approach preference, typically performed via a traditional posterolateral thoracotomy. Though it has been successfully completed via Vats, in highly selected cases, the ultimate goal is to obliterate the residual pleural space by allowing the native lung to expand fully. Lobectomy. Medial hilar dissection. A medial viewing and inferior lung retraction allows direct dissection of the apical hilum through anterior access incision. Apical vascular control, medial viewing and lung holdings allows an endoscopic stapler to safely divide the apical pulmonary artery trunk of the right upper lobe. Fissure dissection, standard viewing and a working port are used to retract the lung and divide vascular structures. Example, pulmonary artery branch to the right lower lobe. Major fissure and ligament. Standard viewing and working port retraction are used to dissect the major fissure and isolate inferior pulmonary vein after dividing the pulmonary ligament. Fissure division and completion. Standard viewing is used to guide stapler through access incision to divide the remaining parenchymal fissures and fully mobilize the specimen. Post-operative management. Care components. Analgesic control. Maximizing patient comfort to encourage deep breathing, typically managed via patient-controlled analgesia. Physiotherapy. Aggressive respiratory therapy and chest physiotherapy are employed to actively drive lung re-expansion. Chest drain removal. Drains are maintained post-operatively and removed once completely lung re-expansion is confirmed and fluid output has subsided. Advantages. There is reduced morbidity, avoids a traditional highly invasive open thoracotomy and its associated drip spreading complications. Patient recovery results in significantly less post-operative pain and faster recovery and discharge timeline. Precision provides high definition magnification of the surgical field, facilitating precise dissection around delicate hilar and mediastinal structures. Disadvantages and limitations. Technical demand associated with steep learning curve. Operative variables. Procedures can exhibit longer duration of surgery compared to conventional open approaches. Intraoperative risk carries the inherent risk of severe injury to major intrathoracic neurovascular structures and airways. Advances. The RATS, robo assisted thoracoscopic surgery, the mechanical evolution. Vats elevates minimally invasive capabilities by replacing rigid instruments with fully articulated robotic arms, overcoming the spatial and mechanical limitations of traditional Vats. Early models relied on an assistant port for suctioning and stapling. The new robotic models feature integrate the robotic staplers, granting the operative surgeon complete unassisted control over the entire resection, including complex pneumonectomies. Involvement of the ablation methods. It is mainly used in the treatment of atrial fibrillation. Atrial fibrillation prevalence now outplaces many common cardiac diseases traditionally treated by the cardiothoracic surgeons. In the VATS, the sequence is insufflation. The left thorax is insufflated to 8 mm, well tolerated hemodynamically via the fifth intercostal space. Then the hilar dissection, elevate fat of the left superior pulmonary vein, reflect phrenic nerve away from the pericardiotomy site. The pericardial axis divides the ligament of Marshall, dissects through the transverse and oblique sinuses behind the superior vena cava and inferior vena cava. The ablation mapping, route a lighted dissector and rubber guide through a pulmonary vein to position the bipolar radiofrequency clamp. Lesion creation, pass a linear ablator to connect the veins, creating continuous roof and floor ablation lines across the left atrium. It is proven to be significantly more effective than catheter ablation alone as the first line treatment for atrial fibrillation. Clearly documented that mortality benefit demonstrated in patients with co occurring heart failure. Thank you.